Hello, my name is Mohammed Sarich, and I'm Director of Non-Invasive Cardiology and Professor of Medicine at NYU. Here's my presentation of endocarditis and its complications. These are my disclosures. Let's start with endocarditis guidelines. Which guidelines can help us understand the concept of endocarditis and its complications? On the most general level, the latest 2020 ACCHA guidelines on the management of patients with valvular heart disease provides a section on endocarditis. With respect to specific endocarditis guidelines, there is a 2015 AHA scientific statement of infective endocarditis in adults, and its European equivalent is the 2017 ASE guidelines for the management of infected endocarditis. And there is also a review article that compares two sets of guidelines. More specifically, American Society of Echo guidelines include the guidelines on the use of echocardiography in the evaluation of cardiac source of emboli, and there is a section that is devoted to emboli related to endocarditis. Now let's start with the definition of endocarditis. Infective or non-infective inflammatory disorder of the endocardium characterized by vegetation formation, a cluster of fibrin, platelets, and inflammatory cells with or without microorganisms. So let's emphasize the key elements: that it could be infective or non-infective, that it's inflammatory, that affects the endocardium, and is characterized by vegetation, whether infective or non-infective vegetations. So now if we look at the aspect of a vegetation, we have four elements. There is a fibrin clot, there is a platelet clot, inflammatory cells, and microorganisms. So therefore, if we have all four elements, we can talk about infective endocarditis. However, in the absence of microorganisms, then we talk about the non-infective endocarditis or thrombotic form of endocarditis. We also call it Marantic or Lippmann-Sachs endocarditis, in particular iteration of non-infective endocarditis. When there is only fibrin or platelet clot, we talk about that the bland thrombus, which is in the differential diagnosis of vegetation. The first description is of endocarditis or a vegetation comes from 1810 by a French physician, Corvisart, who is Jean-Nicolas Corvisart Desmarets, who is a French physician and a primary physician of Napoleon. And this is his essay on the maladies and lesions, organic lesions of the heart and in the big vessels. And he says, on dissection, the large of the mitral valve, which lies before the orifice of the aortic valve, held no longer by the chordae tendineae to the papillary muscles. At its edge, the mitral valve became loose, with many irregular and long vegetations attached to it, resembling certain venereal excrescences. That's the first description of a vegetation. Now let's look at the vegetation composition, vegetation location, and vegetation complications. So vegetation composition, we already discussed, can be infective or non-infective. In the case of infective endocarditis or infective vegetation, there is a positive blood cultures with infective endocarditis specific organism, and in non-infective, clearly, there is no signs of infections. With respect to vegetation location, they can be valvular, they can be located on native valves or prosthetic valves, they can be mural or can be device associated. And with respect to complications of a vegetation, they could be local, around the vegetation itself, resulting in abscess formation or perforation, let's say, of mitral valve leaflets. And also there could be distant complications of endocarditis, and they include septic emboli. Let's start with the vegetation location. Primarily they are valvular, but they can occur in non-valvular locations as well. With respect to valvular vegetation, they tend to occur on the flow side of the valve, which means in the mitral and tricuspid, they occur on the atrial side of atrioventricular valves. And with respect to the aortic or pulmonic valve, they tend to occur on the ventricular side of these semilunar valves. Typically, vegetations on valves lead to acute valvular regurgitation and rarely to an acute valvular stenosis. Let's start with showing examples of individual vegetation on individual valves. Let's start with the mitral valve vegetation. 65-year-old man with fevers and blood cultures positive for Cardiobacterium hominis. This is a parasternal long axis view, and you see that there is a very large vegetation on the atrial side of the posterior mitral leaflet to a large extent, and there is even a smaller mobile echo density on the atrial side of the anterior mitral leaflet. Large vegetations on the atrial side of the mitral valve is typical for mitral valve endocarditis. Now let's get the zoom image. There is a large vegetation again on the atrial side of the mitral valve. And then if you turn the color on, you see that there is a severe mitral regurgitation, which is a characteristic of a large vegetation endocarditis of the mitral valve. We can look at this in a 3D image. This is a so-called surgical view from the left atrial perspective of the native mitral valve with a very large vegetation in this patient. How about the tricuspid valve vegetation? 41-year-old man, intravenous drug user with blood cultures positive for methicillin-sensitive Staph aureus or MSSA. Transthoracic echocardiogram, right ventricular inflow view, right ventricle on the top, right atrium on the bottom. You see there is a large vegetation on the atrial side of the tricuspid valve. Just as in the case of the mitral valve, vegetation of atrioventricular valve, in this case tricuspid valve, tend to occur on the atrial side of an atrioventricular valve. How about this? Another patient with tricuspid valve vegetation, 34-year-old man, intravenous drug user with blood cultures positive for methicillin-sensitive Staph aureus. This is apical four-chamber view, and now you see massive vegetation involving both the anterior and the septal leaflet of the tricuspid valve. These vegetation could be so large that they completely destroy tricuspid valve leaflets, and not surprisingly, there is a torrential tricuspid valve regurgitation. How about the aortic valve vegetation? 34-year-old woman on hemodialysis with blood cultures positive for Pseudomonas and Corynebacterium. Apical five-chamber view, we are focusing our attention on the ventricular side of the aortic valve. There is a large mobile echo density with independent motion on the correct side of the valve, in this case, the ventricular side of the aortic valve, in a patient with an organism known to cause endocarditis, in this case, Pseudomonas. So this is a large vegetation on the ventricular side of the aortic valve. Now remember, on the mitral and tricuspid valve, vegetations tend to occur on the atrial side as opposed to vegetation on the aortic and the pulmonic valve, which tends to occur on the ventricular side. The common theme is the flow side of the valve. If we turn on the color, we clearly see there is a severe acute aortic regurgitation as a complication, aortic valve vegetation, and endocarditis. How about the pulmonic valve vegetation? 19-year-old woman, previously healthy, with blood cultures positive for Streptococcus viridans. Pulmonic valve, we now pay attention to the ventricular side of the pulmonic valve leaflets, and you see there is a large independently mobile echo density on the ventricular side of the pulmonic valve. So correct side of the valve with an organism known to cause endocarditis, in this case, Streptococcus viridans. How about now, let's test our knowledge. Is this an aortic vegetation? We see a simultaneous biplane image of the aortic valve on transesophageal echocardiography. The left-sided image shows the long axis and the right-sided image shows the short axis of the aortic valve. Is this aortic endocarditis? Think of it, yes or no. Large mass on the aortic side of the aortic valve. As we just discussed, the vegetation on the aortic valve tend to be on the ventricular side of the valve. So now we have a large mobile echo density on the opposite side of the aortic valve, on the aortic valve side. That makes the vegetation less likely. The characteristic appearance of this lesion is that of a papillary fibroelastoma. So this is not an aortic vegetation, it's a papillary fibroelastoma. So this case emphasizes the importance of looking for the location of an independently mobile echo density associated with the valve. In this case, the associated independently mobile echo density was on the aortic rather than the ventricular side, and therefore we think that this is less likely to be endocarditis. How about another question to test your knowledge? Is this a mitral vegetation? Again, we are looking at the apical three-chamber view on a transthoracic echocardiogram, and we have a large mobile echo density associated with the ventricular side of the mitral valve. Large mobile echo density on the ventricular side of the mitral valve. Is this endocarditis or not? Let's look at the apical four-chamber view. Again, large, independently mobile echo density, but this time on the ventricular side of the mitral valve. Is this endocarditis or not? Answer, this is not a mitral valve vegetation. It's a papillary fibroelastoma. Again, emphasizing the importance of looking for the proper location of presumed vegetation. This vegetation can and do occur in the opposite side of the valve, but here we're talking about the most common location of a vegetation, the atrial side of the atrioventricular valves and the ventricular side of semilunar valves. Test your knowledge. Is this mitral vegetation? 68-year-old woman with anticoagulant-associated antiphospholipid syndrome, recent transient ischemic attack, and negative blood cultures. So this is transesophageal echocardiogram, and we are paying attention on the echo densities associated with the atrial side of the mitral valve. And they appear in both lesions and what we call the kissing lesions on the atrial side of the mitral valve. We put the color on, and there is some degree of mitral regurgitation at the level of those kissing lesions. So these kissing lesions clearly interfere with the normal function of the valve. So is this a vegetation or not? It's a frozen image on the left during diastole and on the right during systole. We clearly see echo densities associated with the atrial side of the mitral valve. And we can also look at the on 3D imaging from the left atrial perspective. There are two large echo densities in the middle of the valve at A2 and P2 scallops of the mitral valve. They appear on the correct location of the aortic valve, but are they vegetations or not? So this is just a frozen image, anterior and posterior mitral leaflet. So yes, these are mitral valve vegetations, but they are not infective. Remember, blood cultures are negative even after a long period of incubation. So this is mitral valve Liebman-Sachs endocarditis that we visualized in this case by real-time three-dimensional transesophageal echocardiography. And Liebman-Sachs endocarditis is a form of non-bacterial thrombotic endocarditis. Here's Emmanuel Liebman and Benjamin Sachs. They were both New York City physicians at Mount Sinai who originally described it in 1924, hitherto undescribed form of valvular and mural endocarditis. So endocarditis can be infective and non-infective. So in this case, Liebman-Sachs is a form of non-infective endocarditis. How about merantic endocarditis? How is that different from Liebman-Sachs endocarditis? It's a case of a 73-year-old man with the lung adenocarcinoma, deep vein thrombosis, pulmonary embolism, recent stroke, and negative blood cultures. So again, we see large echo densities associated with the atrial side of both the anterior and the posterior mitral leaflet. These are vegetations on the atrial side of the mitral valve in a patient with negative blood cultures, but with the clinical history of an adenocarcinoma. Again, we can see another TE image, and we look at in the bicommissural view on the left and then LVOT view on the right. But again, we see large echo densities associated with the atrial side of the mitral valve. Now you can also look at the 3D from the so-called surgical view, the atrial aspect of the mitral valve showing large densities in the middle of the valve, again predominantly on the A2 and P2 scallops of the mitral valve. And this is a merantic endocarditis, from a Greek word merantikos, which means wasting away. So this is a form of non-bacterial thrombotic endocarditis that it's associated typically with wasting, including adenocarcinoma or other cancers. So what's the difference between a vegetation and endocarditis? Recognizing a vegetation on echo is only one step in the diagnosis of endocarditis. So we have to look at the Duke criteria. They come from Duke University School of Medicine, and they're first published in 1994 and has undergone several revisions since then. So what are the Duke criteria for endocarditis? There are major criteria and then are minor criteria. Major criteria includes positive blood cultures with the microbes that are typical for causing endocarditis. There should also be a positive echocardiographic finding through the and vegetation that it's independently mobile is one of such echocardiographic findings. There could be a positive biopsy or no valvular regurgitation. Among the minor criteria are predispositions, intravenous drug use, prior valvular damage, embolic signs, fever, immune complex deposits, and atypical microbes. So to establish diagnosis of endocarditis, we have typically to have two major criteria or a combination of one major and three minor criteria, or simply 5 minor criteria. In clinical practice, most often we establish the diagnosis of infective endocarditis by 2 major criteria, and that typically implies finding positive blood cultures for an organism known to cause endocarditis and finding positive echocardiographic findings that are consistent with endocarditis. So what are the typical organisms that cause endocarditis? In 50% cases or so, those are streptococci, enterococci, and Staphylococcus aureus in about a third of the cases. Other staph organisms, about 4% of cases, and it's a very rarely that endocarditis is caused by gram-negative organisms, or even less so by fungi. So Staph aureus endocarditis tend to be acute, while a streptococcal endocarditis tends to be subacute, occurring over weeks or even months. So what are Duke criteria for positive echocardiographic findings? So there should be a vegetation, meaning independently mobile echo density on a cardiac valve, supporting structure, or iatrogenic device, or in the path of regurgitant or shunt jet. Independently mobile echo density. We also discussed that has to be on the correct side of the valve in most instances. There can also be a new valvular regurgitation, equivalent to clinical signs of a new murmur. Changing or worsening murmur is not sufficient. Finding of a paravalvular abscess is one of the major criteria for positive echocardiographic findings to establish the diagnosis of endocarditis. And finally, the 4th major criterion is a new prosthetic dehiscence. Now let's start a question. To diagnose endocarditis, should one use transthoracic transesophageal, echocardiogram, or both. So let's look at that, the review article that in the beginning of my presentation I mentioned, that it's review articles that compare European to the American endocarditis guidelines. And you see ASE and AHA guidelines. So now let's look at this, whether we should do transthoracic and echocardiographic findings. If I look at the diagnosis, everybody agreed that echocardiography is recommended as the first-line imaging test in all cases of suspected endocarditis. And they can also, if we are not certain with a transthoracic echocardiography, we can use transesophageal echocardiography. But let's look at this in a summary slide. If there is a clinically suspected infective endocarditis, we start with the transthoracic echocardiography. If the transthoracic echocardiogram is positive, diagnosis is established, and only if we have high-risk features, we can consider transesophageal echocardiogram primarily to look for possible complications of endocarditis. If transthoracic is negative and there is a low risk of suspicion, we consider other cases. However, if there is a high risk, despite negative transthoracic echocardiographic findings, but there is a high risk or high suspicion, we should proceed with the transesophageal echocardiogram. And also, if the transthoracic echocardiogram is inconclusive, we will then proceed to do transesophageal echocardiogram. And then we can then look at the iteration when to repeat transesophageal echocardiogram or transthoracic echocardiogram, and this chart nicely illustrates. Now let's go back to Duke criteria. Independently mobile echo density, and look at the vegetation. So it's a valvular, non-valvular. Non-valvular could be mural, in the path or regurgitant jet or shunt jets, or on the device, catheters, pacemaker, closure devices. Remember in the original part of the presentation, we discussed the valvular vegetation, but now let's look at the non-valvular location of vegetation. Let's look at in the case of left atrial mural endocarditis. This is a 51-year-old man with acute stroke and blood cultures positive for Streptococcus sanguinis. This is a large mobile echo density on the atrial side of the posterior mitral valve. So this finding in the context of a positive blood cultures with an organism known to cause endocarditis are indicative of mitral valve endocarditis. So large vegetation on the atrial side of the mitral valve. So that's the valvular findings. But what's the non-valvular finding here? Here still we see that there is endocarditis and a large jet of mitral regurgitation, that it's eccentric and then hits the posterior wall of the aorta. So let's see whether there is anything in the path of this jet as it hits the posterior wall of the aorta. Severe mitral regurgitation. And now if we zoom on the posterior wall of the aorta, which is in the path of the mitral regurgitant jet, you see there are mobile echo densities that are consistent with the mural endocarditis. So vegetation on the left atrial wall. You can see another TE image, this time a simultaneous biplane with the long axis of the aortic valve on the left and the short axis of the aortic valve on the right. You can see there are mural vegetation on the left atrial wall along the posterior aspect of the aorta. How about the right mural endocarditis? 36-year-old woman with lupus, end-stage renal disease on hemodialysis and chronic anticoagulation for mechanical mitral valve and blood cultures positive for Agromyces mediolanus. It's a very rare organism. See here there is a superior vena cava, there is a dialysis catheter, and there is a right atrial mass in the path of the jet from the dialysis catheter. It's not unusual in patients with the dialysis catheters in the superior vena cava. They have jet lesions on the wall of the right atrium opposite the catheter jet. So this is vegetation on the right atrial free wall. And then another view of it, it's a large mass, mural mass, consistent with the mural endocarditis. So again, it's independently mobile echodensity vegetation on the cardiac valve, supporting structure or iatrogenic device, or in the path of regurgitant jet or shunt jets. Here we saw mural endocarditis of the left atrium in one case and the right atrium in the other, that they were in the path of either mitral regurgitant jet or in the path of the jet from the dialysis catheter. How about an ICD lead associated endocarditis that can occur? This is a 57-year-old man, status post HeartMate 2 left ventricular assist device, then blood culture is positive for Candida parapsilosis. So in this case, we have a fungal organism and we have a device, in this case ICD, but a similar presentation can occur with the pacing leads as well. So this is a transthoracic echocardiogram, modified right ventricular inflow view. Right ventricle is on the top, right atrium on the bottom, and you see there is an ICD lead inside the right ventricle with the large mobile echo densities associated with the ICD leads, in this case, in this patient with fungina. So these are fungal vegetation associated with the ICD lead. And then lead-associated endocarditis. It's important to emphasize that Staphylococcus epidermidis may be a real pathogen rather than contaminant in patients with pacemaker or ICD lead associated mobile echo densities. That is to say, Staphylococcus epidermidis is often considered a contaminant in a blood culture. However, if the patient has a pacemaker or an ICD lead and Staphylococcus epidermidis bacteremia, that should be considered lead-associated endocarditis until proven otherwise. So now let's look at another major criterion in the Duke criteria set, positive echocardiographic findings. This time is a perivalvular abscess, new prosthetic dehiscence. So this is a aortic root abscess. This is 29-year-old man with bicuspid aortic valve, recent stroke, and blood culture is positive for methicillin-sensitive Staph aureus. Again, an organism that it's known to cause endocarditis. So again, this is the aortic root shown on the short axis of the aortic valve on transesophageal echocardiogram. You see that this is bicuspid aortic valve, and there are echolucencies along the posterior aspect of the aortic root, consistent with the native aortic root abscess. Here, not only that the organism is very aggressive, but also there is a presence of bicuspid aortic valve, which is anatomically abnormal valve compared to a normal trileaflet valve. Again, if I change the view, this is at the 0 degrees mid-esophageal view. You see there is a much larger abscess. There is an echolucency, heterogeneous appearance around the native root. Now this is the LVOT view. You see there are echolucencies, there is a density, but also there are echolucencies, and sometimes you can see even septations characteristic of aortic root abscess. More commonly, we saw aortic root abscess associated with prosthetic rather than native valves. This is a 90-year-old man with a bioprosthetic aortic valve, recent stroke, no complete heart block, and blood culture is positive for methicillin-sensitive Staph aureus. Again, we have a known organism known to cause endocarditis in a patient with a prosthetic valve. Again, this is a bioprosthetic valve seen on transesophageal echocardiogram, and there are echo densities along the posterior aspect of the aortic root. And this is consistent with an abscess of the prosthetic root. If I change the view from short axis to long axis, now you see that there is a large echo density associated with the aortic root next to the prosthetic sewing ring, but this time you see echolucency and septation inside the deck, that echo density characteristic of an abscess formation. So abscess formation is characterized by echolucencies and septations in association with the native or prosthetic valve. Again, if I do a simultaneous biplane view, you see particularly in the short axis view, you see large echo density abutting the prosthetic valve, but with the septation and echolucencies in it characteristic of a periprosthetic aortic abscess. How about the new prosthetic dehiscence? That's another major criterion of endocarditis. Here's a case of a 38-year-old man with mechanical St. Jude aortic valve who presents with fever and blood cultures positive for methicillin-sensitive Staph aureus. Again, Staphylococcus aureus is an organism known to cause endocarditis, and the patient has a mechanical St. Jude aortic valve. Again, now you can see that the prosthetic valve is rocking. There is a dehiscence at the portion of the sewing rig next to the mitral valve. So it's aortic root abscess and the aortic mechanical prosthesis that partly eroded, eating up the sutures and leading to prosthetic dehiscence. And now if you turn on the color, there is a clearly paraprosthetic aortic regurgitation. Again, you see on a 3D imaging of the aortic prosthesis from the aortic side. You see clearly there is a dehiscence of the prosthetic valve. The valve is going up and down. This is a highly dangerous condition, and the patient was immediately referred for surgical replacement. Rocking St. Jude aortic mechanical prosthesis as a complication of Staph aureus endocarditis. This is just another view from the side of this prosthesis, and you see the large abnormal pathologic movement of the prosthetic sewing rig characteristic with prosthetic dehiscence. How about summarizing new prosthetic dehiscence? Prosthetic dehiscence in the immediate post-op period may be due to surgical mishaps, such as loose suture. However, thereafter, prosthetic dehiscence is endocarditis until proven otherwise. Now let's go back to vegetation composition, vegetation location, and now vegetation complications. With respect to vegetation and composition, we talked about infective and non-infective endocarditis. With vegetation location, we discussed the valvular and non-valvular vegetation locations, including mural and device-associated vegetation. And now let's discuss vegetation complications, which can be local, such as abscess and leaflet perforation, and could be distant septic emboli. We have already encountered abscesses of native and prosthetic valve. So now let's look at the leaflet perforation. 68-year-old woman with the new onset of congestive heart failure and blood cultures positive for Streptococcus aeruginosus, another organism that is known to cause endocarditis. Here, this is a transesophageal echocardiogram. We are looking on the aortic side of the anterior mitral leaflet. Remember, we are looking at the atrial side of the mitral valve leaflet, independently mobile echo density in a patient with the blood cultures positive for an organism known to cause endocarditis. That therefore we would have two major Duke criteria to establish the diagnosis of mitral valve endocarditis. So there is a large vegetation on the atrial side of the mitral valve with the positive blood cultures. Now let's look at a simultaneous biplane view. Again, on the left-hand side is the original image, and now on the right-hand side we see the perpendicular or 90-degree angle of the same vegetation. And now we can see that there is a severe mitral regurgitation, and the mitral regurgitant jet occurs through the vegetation due to leaflet perforation. And again, if we look at now on the 3D imaging of the mitral valve from the left atrial perspective, you see that the base of the anterior leaflet is perforated. So anterior leaflet perforation due to endocarditis. How about other complications of endocarditis, such as pulmonary septic emboli in a 34-year-old man, intravenous drug user with blood cultures positive for methicillin-sensitive Staph aureus? This is a chest X-ray of that patient with the diffuse bilateral nodular densities They range to 1 to 3 centimeters and may increase in number or change in appearance, size, or degree of cavitation of subsequent short-term follow-up radiographs. There could be also emboli to the systemic circulation if they occur if the endocarditis is left-sided. So here, such a systemic embolus to the brain of a patient, or often they occur to the spleen, or they can also occur to the kidneys in this patient with both kidneys affected by septic emboli. So septic embolism, risk of septic embolism is directly related to the size and the mobility of a vegetation, and risk of septic emboli drops precipitously after initiation of antibiotic therapy. How about another complication of endocarditis, and that's intervalvular fibrosa endocarditis. Let's look at a little bit of the anatomy of the mitral aortic intervalvular fibrosa. Normally, there is a continuity between the aortic valve and anterior mitral leaflet. If I zoom on this image, this is where the aortic valve ends, and this is where the mitral valve starts. And in between the two of them is the portion of the tissue referred as intervalvular fibrosa, or sometimes referred to as aortomitral curtain. They're also called intervalvular or intervalvular space, aortomitral curtain, intervalvular fibrosa. These are all the synonyms. And then if you look at this autopsy specimen, in this, the intervalvular fibrosa is referred as mitral aortic intervalvular fibrosa, or MAIF. This is a little bit zoomed image. You see that there is a space between the end of the aortic valve and the onset of the mitral valve. So what are the complications and how that occurs of the endocarditis of intervalvular fibrosa? It typically starts as aortic valve endocarditis, and often of a congenital abnormal or a prosthetic valve. And the next step, there is infection extension, whether that occurs by a direct extension from the aortic valve into intervalvular fibrosa, or as a jet lesion from aortic regurgitant jet hitting the intervalvular fibrosa. And in the next step is there is a complications, there is abscess, aneurysm, or leaflet perforation leading to mitral regurgitation or tamponade. So let's look at the intervalvular fibrosa abscess. So clearly there is an endocarditis of the aortic valve, and there is extension of this endocarditis into the intervalvular fibrosa, and I see there is echolucency and septations characteristic of an abscess. So this is endocarditis of the native aortic valve caused by Staphylococcus and leading to a complication of intervalvular fibrosa abscess formation. So again, we can look at this in a 3D from the modified surgical view of the mitral valve, zoomed image. So this is abscess of the intervalvular fibrosa or aortomitral curtain. Another complication of intervalvular fibrosa is the aneurysm formation. So this is intervalvular fibrosa aneurysm, which actually can form after the abscess drains. So again, you can see there is a aortic regurgitant jet hitting the intervalvular fibrosa, causing this aneurysm formation. But you can also notice that there is the aneurysm itself is not perforated yet, as there is no jet going into the left atrium. So this is aneurysm of the intervalvular fibrosa seen on color Doppler imaging. Again, we can look at this on a 3D imaging. This is aneurysm of intervalvular fibrosa. And as I will move the image side to side to better visualize this protuberance of the intervalvular fibrosa just above the mitral valve seen on the modified surgical view of the mitral valve. How about the Streptococcus mitis aortic valve endocarditis in intravenous drug user? And you see there is a perforation of the intervalvular fibrosa. So just above the mitral valve, there is a hole that leads to severe jet that it's physiologically equivalent to mitral regurgitation, but this is technically LVOT to left atrial shunt through a perforation inside the intervalvular fibrosa. It's a perforation. You see a nice piece of formation just before the hole in the intervalvular fibrosa, continuing as a regurgitant jet, similar to mitral regurgitation. And this is a false aneurysm or left ventricle due to perforation of mitral aortic intervalvular fibrosa and rupture and lead to cardiac tamponade. This is another case that rarely can occur. Intervalvular fibrosa can perforate into the pericardial space and cause cardiac tamponade. And this is from that original paper. It's rarely, I have not seen it in my personal practice yet. This is perforation into the pericardial space, causing purulent pericarditis and tamponade. How about another case of a 65-year-old, previously healthy and very fit man. A year ago, he started to feel non-specific generalized malaise, absence of fever and leukocytosis. 2 months ago, he was diagnosed with a new systolic murmur. TT interpreted as showing myxomatous mitral valve disease at another institution, and a week ago, he saw a hematologist for a low-level paraproteinemia. So he was also noted to have anemia, thrombocytopenia, and splenomegaly. So there were elevated inflammatory markers and ESR and CRP. So hematologist saw the patient, and this is what hematologist wrote in his conclusion. I am concerned that this represents subacute bacterial endocarditis. This is extremely insightful hematologist. And let's look at the transthoracic echocardiogram. Again, this is, you might have recalled, at the very beginning of the presentation, I showed you this an example of the mitral valve vegetation, mobile echo density on the atrial side of the posterior leaflet. So interpreted, unfortunately, by the outside cardiologist as a P2 scallop prolapse. This is clearly not a prolapse, but a vegetation. You look at the four-chamber view, there is a large mass associated with the posterior leaflet of the mitral valve. Look at the color, again, severe regurgitation, which is a known complication of acute bacterial endocarditis of the mitral valve. So blood cultures grew gram-negative rods in multiple bottles. Patient then underwent transesophageal echocardiogram, and now you better see these mobile echo densities associated with the mitral valve, particularly the posterior leaflet. If you turn the color on, you see there is a significant mitral regurgitation, which we have already seen on transthoracic echocardiography. Now let's look at again this mobile echo density associated with the atrial side of the mitral valve. Let's freeze it and see the elements of this. You can see that there is a central lucency, that this vegetation is already cavitating. If you look at the now on a 3D TE view of the mitral valve from the so-called surgical perspective, the left atrial perspective, we can see that there is a large mobile echo density on the atrial side of the P2 scallop of the posterior leaflet of the mitral valve. So TE conclusion, large, partly calcified and nearly perforated vegetation of the P2 scallop of the posterior mitral leaflet. Blood cultures, then several weeks later, they grew gram-negative rods speciated as Cardiobacterium hominis. This is a Cardiobacterium hominis in culture, and it's a part of normal flora in the oropharynx. And then this is Cardiobacterium hominis, and it's a part of a larger group of organisms, gram-negative, fastidious organism called the ASE group. And these are the other members of this group. So at the time of this case, we diagnosed it with the ASE organism. So ASE is actually a play on a Czech word Hacek, which denotes these doodads above C, S, and Z. And ASE organisms are responsible for very few endocarditides, probably around 2% of all endocarditides, and they are fastidious. Blood cultures require very special media to grow them, and it takes time to those cultures become positive. What are the further development? He subsequently developed heart failure, and he was referred for valve surgery. This is intraoperative TE using a TrueView 3D technology on echocardiography. Now you can actually see on the atrial side, there is a very large vegetation on the atrial side of the posterior mitral leaflet. And remember, ASE organisms are characteristic with the large, characterized by large vegetation, just as is the case of this patient. Another view, slightly from the side, of this large mitral valve vegetation on the posterior aspect of the valve. And yet another view, very large mobile echotensity on the correct side. And now this is from the ventricular side of the valve. It's a large vegetation, frozen image. And now if you turn the color, you see there is a significant mitral vegetation at the level of the vegetation. So, and then this is intraoperative video. You see there is a large vegetation on the posterior aspect of the mitral leaflet, but also there is a smaller vegetation, a kissing lesion on the A2 scallop of the valve. So large posterior leaflet vegetation and a smaller anterior leaflet vegetation. And this is the intraoperative specimen from the posterior leaflet, large vegetation, smaller vegetation from the anterior leaflet. And then patient underwent mitral valve replacement using Medtronic mosaic bioprosthesis, properly functioning, and the patient did really well. So this is from the left ventricular side, and then from the left atrial side of the patient, and the ventricular side of the valve. So conclusion, this was a Cardiobacterium hominis, and a member of the ASE group. Is a very rare cause of endocarditis, but we have to think of it whenever we see large vegetation. And TrueView technology allowed us for better visualization of this vegetation. But interesting, HASEC is no longer called HASEC, but has recently been renamed ASEC. And why is that? Because the previous organism, which was called Haemophilus, now it's called Aggregatibacter afrophilus. And then instead of HASEC, now we called ASEC. And recently we showed this on Twitter. If you're interested, you can look at this. And this is ASEC endocarditis of intervalvular fibrosa. So nicely summarizes several of the aspects. So there is a large vegetation from the side, and then you see that it involves intervalvular fibrosa leading to leaflet perforation. And now we can actually see on a 2D imaging that there is a perforated intervalvular fibrosa leading to severe mitral regurgitation like pathology. I hope you enjoyed this presentation, and thank you very much for your attention.